Good afternoon. I'm Cindy Hall, president of the Women's Congressional Policy Institute, or WCPI. Welcome to our Capitol Hill lunch briefing, Reducing Maternal Mortality in the United States. Thank you to those of you who are attending in person and those who are joining our live stream. Welcome. As most of you know, WCPI is a nonpartisan, nonprofit public policy organization whose mission is to bring together a community of bipartisan women policymakers and trusted partners to advance issues of importance to women and their families, develop the next generation of women leaders, and foster a more effective and representative democracy. We work closely with the members and staff of the Bipartisan Women's Caucus. Maternal health has been a priority issue for the caucus and our organization for decades. Today, we will be hearing from a very distinguished panel, including Dr. Diana Bianchi, Dr. Keisha Callens, Erica Lynn Cotton, and our moderator, Shefali Goyal. Each of them will bring a different perspective to this important discussion, and we thank them for participating. Our special thanks to Organon for their support for this briefing. We appreciate their commitment to reducing maternal mortality and improving maternal health outcomes. I would like to thank our congressional briefing co-sponsors, the leadership of the Bipartisan Women's Caucus, Congresswomen Kat Cammack and Susie Lee, co-chairs, and Congresswomen Monica De La Cruz and Amelia Strong-Sykes, vice chairs. We will be posting live on social media during the briefing. We encourage you and others to do so by using the hashtag WCPI Health. I am now very pleased to introduce Congresswoman Robin Kelly, who I think this entire room knows is such a champion for this issue. She represents Illinois' 2nd Congressional District and serves on the Energy and Commerce Committee, including the Health Subcommittee, which, as everyone knows, has such key work around this issue, responsibility. And Congresswoman Kelly is co-chair of the Bipartisan Maternity Care Caucus. She has introduced legislation to improve maternal health care outcomes in both rural and urban areas. Congresswoman Kelly.
Good afternoon, everyone. I am so grateful to the Women's Congressional Policy Institute and the Bipartisan Women's Caucus for hosting today's briefing. As you might know, ending maternal mortality has been a passion of mine for almost my entire time in Congress. I'm terrified that my daughter and my stepdaughters are in more danger of giving birth than I was when I had my children, and I had 2 cesareans many moons ago. Just a few years ago, barely anyone knew that this was an issue, but now we have the data and more people than ever are paying attention. And this isn't an isolated problem. My district is urban, suburban, and rural. There are parts of my district where only one OBGYN serves a population of over 30,000 people. Hospitals are closing their labor and delivery units without notice. Lack of broadband access means that some expecting mothers can't even have a basic telehealth appointment. I represent an area where some people can't get online because they don't have the infrastructure. So of course, we're working on that now. Nationally, as you know, Black moms are 3 times more likely to die of pregnancy-related causes than their white peers. But in my home state of Illinois, despite all the things Illinois has done, the disparities are even greater. Congress must work together on both sides of the aisle to protect our moms and babies and our families. That's why I'm urging my colleagues to support my Care for Moms Act, which takes a holistic approach to ending the maternal mortality crisis, because we know that we can't have a one-size-fits-all solution. The Care for Moms Act will establish grants for rural obstetric mobile units, empower doulas to support mothers, and give HHS the power to ensure that maternal health resources are equitably distributed and get to the communities that need them most. But Congress cannot do this alone. That's why I'm so happy to see all of you. We need close collaboration between local, state, and federal government. We need to collaborate with communities, with hospitals, with birthing collectives, with doulas and midwives. That is why I'm so grateful to be here with you today, because so many of you are dedicated to this cause. We must work together. We can ensure that no mothers face the challenges of pregnancy and childbirth without the care, support, and resources they deserve. We all know that we can do better, and we must do better, because so much of this is preventable. And because I'm an optimist, I'm a member of Congress, I know we will do better. So thank you so much. If I have to run out the door because I'm in a hearing and my question's coming up in E&C.
Thank you so much, Congresswoman Kelly. We so appreciate your commitment. It truly is a passion for you, and we are grateful for your leadership. I am now pleased to introduce Shefali Goyal, who will introduce each of our speakers and moderate the discussion. Shefali is the Vice President and Head of Global Product Regulatory Strategy and U.S. Regulatory Affairs and Affiliate Pharmacovigilance Lead at Organon. And you're laughing. I actually practiced that, didn't do so well this time. In this role, she is responsible for shaping the evolution of regulatory capabilities at Organon and focusing on the delivery of regulatory strategic excellence across the enterprise, optimizing interactions with the Food and Drug Administration and other key health authorities. Shefali received her bachelor's degree in zoology from Delhi University, master's in microbiology from the Indian Agricultural Institute, and a master's in molecular genetics from Cornell University. Just a few degrees.
Thank you very much, Cindy. Can you guys hear me okay? Well, good afternoon, everyone. I am Shefali Goyal, and I'm heading up the regulatory strategy for short at Organon. And I am so thrilled to be here today to talk about a topic that I'm passionate about, just like most of you here, which is reducing maternal mortality in our country, the United States of America. It is, we just celebrated Mother's Day this weekend. And today is a day that we should think about that there are many families who have lost their mothers or nearly lost their mothers because of maternal complications. In the US, two women die every day with postpartum hemorrhage. Globally, while we're sitting here for 90 minutes, 15 women would die of postpartum hemorrhage. So this is a sobering topic that we have to talk about. And as Representative Kelly also pointed out, women of color are 2 to 3 times more likely to face these maternal complications. So today we are here to talk about this sobering topic, as well as the work being done to reverse the trends from our panelists today. We'll hear about the need to increase research, investment, education, and programs to deliver innovations that can significantly improve care, health equity, and outcomes for women and their families. Now, I'm honored to introduce the first of our 3 panelists who will bring this topic to life with her personal story. I'd like to welcome Erica Lynn Cotton, who is a survivor of postpartum hemorrhage, a registered nurse and CEO and founder of Beauty Over Ashes. She lost her husband during her pregnancy, then later experienced postpartum hemorrhage, where she received compassionate care from her providers and doula. Her experience inspired her to found Beauty Over Ashes, a nonprofit providing resources and community for mothers, children, and young widows. Erica Lynn utilizes her background as a registered nurse, specializing in women's health, and as a certified breastfeeding counselor to empower and educate women and their families across the country by providing community resources such as perinatal support, mental health resources, and childcare grants. Erica Lynn, please.
Good afternoon, everyone. My name is Erica Lynn Cotton, and the way she wrote that and said that. That was great. I would love to meet that woman. She's amazing. And so today I am here to share a little bit about my story and my experience with postpartum hemorrhage. A little background of who I am. As she said, I am a labor and delivery nurse. And so let's keep in mind that the story that I'm about to tell you is at the hospital that I worked at as a labor and delivery nurse. So everyone involved in my care were also coworkers and they knew me personally. So just keep that in mind as you think about the fact that I am educated, the fact that I knew all of my providers personally and had a relationship with them, and these things still happen. And so a little bit about a hemorrhage. Technically, a hemorrhage is considered losing 500 mLs or more of blood. My hemorrhage was a little bit different in the fact that I lost 200 from my uterus, which is a typical hemorrhage, and then the other 350 came from a vaginal tear. And so with my personal medical history, I have fibroids. So this was something that we all considered during my pregnancy. We knew that it increased my rate and my likelihood of having a hemorrhage. So that was something that we took into consideration as protocol when I was delivering. I delivered in Philadelphia at a hospital that had a hemorrhage protocol. So they take into consideration what the patient's history is, and if we are likely to have a hemorrhage, we put these things in place. So we knew that I had hemorrhoids. We knew that I had fibroids, and I did not have hemorrhoids. We knew that I had fibroids, and we knew that I was at an increased risk of having a postpartum hemorrhage. So they were prepared in the sense that they had Pitocin and all of the things that we would use. We did not take into consideration that I would lose so much blood vaginally. So during the delivery of my daughter, she was my first child. And while I was pushing, I experienced multiple tears, which is normal for someone who is having a baby for the first time. And we did certain things to protect that area to make sure that it didn't rip as severely as it could have. However, I did rip a lot more than what is, wanted. And in which case I lost a lot of blood. One of the reasons why I lost so much blood was because I had poor skin integrity. And this is something that we can't calculate. We don't know what the tissue is going to be like when someone delivers a baby. One thing we didn't consider that could have contributed to the fact that I had that poor skin integrity was nutrition. So when I'm 7 months pregnant, my husband dies unexpectedly, right? And when you think about a pregnant woman, you think about all of the things that she's going through. She's growing this baby inside of her body. One thing that wasn't considered, right, is let's go ahead and make sure that mentally she's coping the way she should. But when you think about depression, when you think about different tragedies that people experience and trauma, the first thing that you think about, oh, this person probably isn't going to eat and take in as much nutrition as they should. And so although I'm drinking all the protein shakes and the Ensures and all those sorts of things, I just naturally did not have an appetite. So that's one of the factors that contributed to the fact that my skin integrity was so poor and I lost so much blood during that immediate postpartum period. And so one thing I was grateful for is that I had an amazing team. I had a midwife who took care of me. I was being seen by maternal fetal medicine because I had a high risk pregnancy. And they were also very interactive in making sure that I got the mental health care that I needed as well. So it's really, really important. And one thing that I took away so much from the experience is like looking at somebody as a whole person. And I was grateful and lucky that they knew me personally. So they looked at me as that whole person, but not only taking into consideration that I have fibroids, but also understanding that I was going through a traumatic event. And when going through traumatic events, it impacts your body in a way that many other pregnant women may not be impacted. They may be impacted, from a lot of different things that are going on geographically. They may be impacted by work-life balance and just being exhausted. But when you add the level of trauma, when you add grief and loss, and you add those chemical imbalances that happen in your body while you're also creating and providing nutrients to a human, these are also things that need to be considered. So even when thinking about postpartum depression. I think a lot of times in postpartum mood and anxiety disorder, it's also important to think about what the pregnant woman is going through. I had a very traumatic event that happened to me that was very obvious that I would need the mental health and those types of supports. But there are women who experience so many other things that are going on in everyday life that also can attribute to them having poor nutrition. We talk about deserts with healthcare and not having enough hospitals. Well, in those areas that don't have enough hospitals, they probably don't have supermarkets and fresh food and vegetables either. And so when we think about the whole person and we think about nutrition and we think about mental health and we think about their physical health, you know, how are they getting back and forth to work? Are they working so much that they aren't able to walk into exercise? And we think about those comorbidities that, you know, women face. Luckily, I didn't have preeclampsia, I didn't have high blood pressure, I didn't have all of those things, but these are all things that contribute to the health and wellness of a pregnant woman. And when we have these things that are also going on with us simultaneously while we're pregnant, it could potentially lead to something that's more deadly, like a hemorrhage or, you know, all those other comorbidities that take the woman down the path of things that are avoidable and preventable while pregnant. And so my goal is to highlight and understand that these things happen there are things that happen during pregnancy that are preventable and avoidable and treatable. And then there are also things outside of our control that happen. And so I created Beauty Over Ashes because it was something that didn't exist that I realized was needed. I needed someone to make sure that I was getting the proper nutrition that I had. I needed someone who was going to be who I could talk to about the different things that I was facing so that I didn't go down that road of a deep depression. I needed a doula. And so we provide doula services for people to advocate because now I'm having this baby, but I don't have my husband. And so when I got pregnant, I had him and I knew that he would be there for the delivery. I knew that he would be able to advocate for me at times when I couldn't advocate for myself. But when that dynamic of the family structure is broken, now who does that mom have to turn to? And so we like to provide doulas to people who don't have someone to ask the questions, to advocate for them, because we know that a lot of these deaths are preventable if somebody just listens to what the woman has to say. The woman knows her body much more than anybody outside of her body because she's been living in it for however many years she's been alive. And I think that one of the things that was important in my case was that everything that happened to me, I was able to verbalize it, not only because I knew what was happening from an educational standpoint because I was a nurse, but also because my providers were willing to listen. And when something happened, they were willing to, I would call and I would say, I know I'm bugging you, I know I'm bothering you, but this is happening. And they're like, no, absolutely, we want to hear it. And so I think it's very important to have providers who will listen to you, especially when it comes to those things that are preventable and avoidable. And so that's a little bit about me and my story of having a postpartum hemorrhage.
Wow. Thank you, Erica Lynn, for sharing your personal story and I think for inspiring the rest of us and also emphasizing the importance of taking care of the mother, the nutrition, and really having a voice, either yourself or somebody supporting you to make sure that you have a healthy pregnancy and delivery. So thank you very much. Okay, so and now our next speaker is Dr. Keisha Callens. She is an OBGYN at Community Health Care Systems, which is committed to providing healthcare services to rural and underserved areas in Central Georgia. She is also a professor at Mercer University School of Medicine and serves as the faculty advisor for the OBGYN interest group. Dr. Callens is the immediate past chair of the National Advisory Council for the National Health Service Corps and a former National Health Service Corps scholar. Dr. Callens earned her bachelor's degree in biology from the University of Virginia, master's in public health from the University of Alabama at Birmingham School of Public Health, and her medical degree from the Morehouse School of Medicine. Please, Dr. Callens, come on.
Good afternoon.
Good afternoon.
Good afternoon. I was waiting. This is an interaction. And greetings from Georgia, also known as the Peach State. I would like to open my remarks today with an adaptation from one of my favorite books, and there's a quote that I love. The book is The Power of Lift, How Empowering Women Changes the World by Melinda Gates. And my adaptation is, no woman should die or almost die while giving life. This is a shared value on which we can all agree, and it is the epicenter of everything we must do to preserve lives across our nation. We're gathered here today to continue to elevate the awareness of maternal mortality crisis in our nation and to expound on one of the major causes as it relates to postpartum hemorrhage. We also would like to extol the nationwide initiatives and interventions that are underway to address maternal mortality. But more importantly, we want to empower all interested parties and partners to continue to become advocates, activists, and ambassadors for the radical improvement that we need to change maternal health outcomes in our nation. So when I counsel a mom that's admitted to labor, I frequently say our goal is to have a healthy mom and a healthy baby. If they're coming in for a vaginal delivery, we hope it goes well. Sometimes we have to change our route of delivery, which is perfectly fine. I tell moms, either you push or I pull, we're going to get the baby out. But more importantly, we want our moms to go home with their babies, hopefully at the same time, not otherwise. And so that's why the conversation about maternal mortality is so important, especially when it comes to hemorrhage. And so I say that out loud to the moms in the room because I want them to hear that, an audible reminder that that is our goal. But it's also an important reminder for my labor and delivery staff to know that that's our goal. But it's also an internal reminder for me as well that we have a goal in mind. One of my favorite books is The 7 Habits of Highly Effective People. I've kind of borrowed that initiative to the 7 habits of maybe a safe delivery. So we begin with the end in mind. And sometimes just by saying that out loud reassures everyone in the room, both the mom and her family, her support system, as well as the staff involved, we have a shared goal to make sure the outcomes are well. So I want to do a quick background for our legislators. We know that far too many mothers die after childbirth, period. Most of the deaths that occur are deemed preventable, but as we heard from our wonderful testimony, there are some things that are outside of our control. The most common things that we see are postpartum hemorrhage, things related to cardiovascular disorders, stroke, and also now perinatal mental health is becoming something that's on the radar that we do have to consider. We know that there's a striking disparity across communities based on color, sometimes based on age, and there are a lot of social determinants of health that impact how the outcome can happen for women. So in full transparency, as you know, I'm from Georgia, our state rankings are uncomfortably close to the bottom. Not very proud of that. And if you look at the most recent March of Dimes Maternal Vulnerability Index, we also have a failing grade. So full transparency. But today we're not here to focus on our prolific problems, right? We're here to highlight and pursue sustainable systemic solutions that can not only save our maternal lives, but improve the quality of our maternal lives, because we know that when moms dazzle, everybody shines. So quick biology lesson that was introduced, of course, by Erica Lynn. I want to tell you that nature is on our side. Blood volume, heart rate, and also how much output comes from the heart naturally increases in pregnancy to support mom and the growing baby. How awesome is that? That change in blood volume is actually done in advance because there's an anticipation that when mom delivers and when the baby is delivered and the placenta follows, there's going to be some blood loss. So nature has given us an advantage by increasing that volume. Postpartum hemorrhage, as mentioned by Erica Lynn, is determined based on the type of delivery. If it's a vaginal delivery, it's usually 500 milliliters, which sounds like a lot. It actually looks like a lot. But if it's a C-section surgical procedure, it's going to be a little bit more. So we expect that that will happen sometimes. Acute postpartum hemorrhage usually happens within the first 24 hours. And that is a very critical period in terms of our ability to assess and diagnose things. But I also want you to know that postpartum hemorrhage, the factors that can impact that can often be divided into 2 different categories. And so I'm doing a little biology just to give you some background. There are primary causes, for example, laceration, which is very interesting because there's a long list, and I picked laceration, which you mentioned, which can happen. But also you can have worsening coagulopathy or The simple way of describing that is the clotting factors in the blood may change. That can happen sometimes with things like preeclampsia that progress to syndromes that affect the clotting factors, and you can actually develop bleeding or hemorrhage related to that. But then there's secondary causes like infection, for example, or if there are retained products, the placenta does not release like it's supposed to. So those are some of the things that can be happening. And what's going on usually in that first 24 hours is being able to go through your list to figure out what the problem is, what the source is, so then you can work on fixing it. And then I also want to mention that we think about obstetric hemorrhage usually in the terms of a actual full-term birth or a preterm birth, but we can see that with a miscarriage, and we can see that with ectopic pregnancies. I've done plenty of procedures for women that have had an incomplete miscarriage and they're bleeding, and we have to go in and do surgery to help that out. So let's get to the heart of the matter. I want you to ponder another quote, and for those of you that know me or will get to know me, I love quotes. But I want you to think about this one. When a flower does not bloom, you do not fix the flower. You fix the environment in which the flower grows. That means you're changing the soil, the light exposure, water, whatever else is needed. All those things are important. And so I want you to use that same framework as we walk into the next step. And remember, we're not here to focus only on our problems. We're focusing on solutions. So a quick brag to our legislators in the room. Are we making progress? Yes. Is the reach far enough? No. Is it fast enough? Never. It's never fast enough. We can always do more. But let's not forget, we have to give ourselves a little bit of grace. We just barely made it through a whole pandemic. We can't forget that. That was a big deal. And it's not quite in the rearview mirror just yet. There are a lot of bills that are being lobbied and a lot of programs that are being funded and implemented nationwide. I mean, you hear about maternal mortality all the time, and there are lots of things that are happening that are very active, and for that, we are very grateful. I don't have a lot of time, so I just want to really touch the tip of the iceberg for what we're doing in Georgia. Through our Department of Public Health, we have the Georgia Perinatal Quality Collaborative, which has been very active in working on implementing a lot of the programs that are now available nationally that we can do. We have implemented AIM initiatives. You probably are familiar with the Alliance for Innovation of Maternal Health. I'm used to the acronyms, and so I have to read the whole thing so that way you know what I'm referencing. In terms of the obstetric hemorrhage AIM, we have about 82% of our hospitals that have been participating in that program. And with them being on board, we've moved from more of the crisis numeric to more sustainability. Although we're not yet at our goal, we're at least not as bad as we used to be. So how is that happening? We have a lot of trainings that are helping our systemic responsiveness through changing order sets to make things accessible, doing drills with the staff to make sure everybody's on board, having hemorrhage carts that are available, and then also implementing mass transfusion protocols that are very important to be able to access the products. When I started my practice many years ago, I won't say the number, I remember I had a patient who came in that had a placental abruption, and she started bleeding after we were able to successfully do a vaginal delivery. And usually I tell patients that when a patient goes into DIC, the blood starts dripping and it just splatters like water. And we had a pretty big deal going on. But at the time, we did not have a mass transfusion protocol. And so literally every nurse on the floor was taking turns going to the blood bank to get 1 unit of blood or FFP or platelets at a time. Shortly after that, we changed that. So now you get a box that has everything in it. But prior to that, literally you had people physically walking back and forth. So those small changes are really big changes in terms of the responsiveness and the rapid way that you can assess things. I want to give a special shout out to the California Maternal Quality Care Collaborative. They've done a lot of work nationally as well to really help to push things forward in terms of creating toolkits that are accessible. Here at home as well, a lot of our medical schools are working on doing very strategic recruitment from our rural communities. Georgia has 159 counties. Only 82 of those counties have an OBGYN. Both of the counties that I work in do not have an OBGYN. I'm the only one that have been for probably almost 8 years. So one of the things that we're doing is trying to recruit future physicians, midwives, other healthcare professionals to really be interested in going back to serve in their community. I also want to thank our legislator for their support of programs like the National Health Service Corps, which continues to serve as the backbone of a lot of the care that's delivered in our country. Most recently, they added the maternal care target area designation, which allows us to be very strategic also in placing physicians to work in those communities. So that's important because what we have really is a maldistribution of the workforce. And part of the things that we need to do in addition to being able to be responsive to our patients is being able to have things that are available and have the right personnel in place. And we not only have to recruit our healthcare professionals, and that's OBGYNs, family practice physicians, midwives, doulas, we have to keep them there. We want them to stay, which means we have to work on how we engage their family as well. So as I'm wrapping up, a quick beg now to legislators. So I gave you background, I gave you biology, I gave you my brag, and now I'm begging. We need to restore the beauty of birth. And I want you to ponder that for just a second. On Monday, I had a friend who I shared that I was having this honorable opportunity to present to you today. She's a beautiful family, and they're expecting their 4th baby girl. 4 girls, that's a lot of hair to comb. She made a comment that really resonated with me that I want to share with you. And I'm going to quote it exactly. She says, "I focus so much on paying attention to not dying, I never get to enjoy the beauty of the delivery." That really stuck with me. Her anxiety is appropriate, okay? At the very least, this is her 4th pregnancy. Her uterus may not contract as well as we would like it to when she does deliver this time. In addition, if she has any kind of augmentation with her delivery for whatever reason that's necessary, or if she were to develop some kind of infection for being in labor for a long time, all of those things are going to further elevate her risk of a postpartum hemorrhage. This is a mom that's having her 4th child. So her healthcare team should anticipate it. They should be prepared to recognize it. They should be prepared to intervene quickly if necessary. However, this healthcare responsibility does not rest only on the shoulders of the physician or the midwife or the doula or the nurses in the room. It extends to the capacity of the hospital to be able to recruit and retain adequate staff that have been trained, adequate medications, adequate blood products. Sometimes the hospitals where I am, you may not have many blood products. Adequate OR staff, adequate access to the operating room, and adequate infrastructure for transfer to a tertiary care hospital if the need should arise in a quick manner. And I've had cases where I've worked in rural hospitals, you spend, 20 minutes calling different ambulance companies. I've called 9 companies, everybody's not available. I've had to use a helicopter to get a patient to another facility. Thank God I had the access to a helicopter to get there in 10 minutes. But also if the weather is not good, you don't have that option. And so all those things have to align for your patients to have what they need. And so that responsibility extends outside of the hospital, extends outside the delivery room, and it rests on everyone's shoulders. So my dear legislators, I want to tell you that your courageous leadership regarding policy decisions have an indelible impact on the environment in which our mothers and babies can thrive. And we talked about environment. Our maternal mortality crisis requires all hands, all heads, all hearts, all feet on deck in order for us to make a difference. I beseech you to adopt a hypervigilant commitment to optimize access and quality of care for women before, during, after, and beyond pregnancy. And here's the true challenge. That needs to happen regardless of demographics or geographics. That's the challenge. We will achieve maternal health equity when we operate from the core value that all maternal lives matter. We need disruptive innovation, creative collaboration, and what I've termed a new word, out of this world care coordination. New technologies, remote monitoring, home visitation within 3 to 5 days of delivering, patient navigators, the list goes on. I'm sure you have your own things that you'd like to throw into that list. This comes with a price tag. We know that nothing is free. So we must budget effectively and maximize the efficiency of our dollars, but there is no price tag that can cover the value of life of any of our loved ones. And one life lost is just one too many. So in closing, another quote coming up, you're not surprised. I will offer another adaptation of one of my favorite quotes from our former Surgeon General, Dr. David Satcher. And my version reads, "We need legislators who first care enough. We need legislators who learn enough. We need legislators who do enough, and we need legislators who will persevere until the job is done." To our legislators that are here today, in the room, to those watching via live stream, to those who may be listening to the recording later on, thank you for being here. Thank you for the work that you do. On behalf of our mothers, our babies, our families, and communities across the nation, lead the way. Thank you.
Wow. Thank you so much, Dr. Callens. I'm glad this is being recorded because there was so much information in that. So definitely something to listen to and take notes. So thank you very much for walking us through the biology of the delivery room, and also pointing out and emphasizing that the right people need to be not only in the delivery room, but also you need the right infrastructure outside. So thank you very much. Now I'm gonna turn to Cindy for a minute because we have some new audience.
Also, thank you, Dr. Callens and Kirkland, both of you, for your incredible presentations. We're very fortunate to have Congresswoman Jan Schakowsky join us. She is an example of one of those legislators that you mentioned. She cares deeply. She's incredibly smart. I've had the pleasure of working with her ever since she got elected. She's a senior member of the Energy and Commerce Committee and Subcommittee on Health, and also one of the co-founders of the Black Maternal Health Caucus. Congresswoman Schakowsky, we'd love to have you say a few words if you'd like. Okay. I think you could probably hear me.
Yes, we can.
I am so proud to be working with my colleagues on this issue of maternal mortality. This was an incredible description of all the things that need to happen. What I remembered so much is hearing from the mother of a doctor, a Black doctor, who died largely because attention was not paid to her. And we see that when it comes to maternal mortality, that Black women are much more vulnerable. And so in addition to all of the medical precautions, all of the people that need to be involved, we have to make sure that there's no discrimination.
Yeah.
And I am so happy to be here for at least a little while to hear from all of you. And I'm glad to see the good turnout. We have a lot of work to do to make sure that there is equity in the system, as well as the competence that we need in this system. So I want to thank all the presenters and all the work that is being done. I'm going to be working side by side with you until we get what we need. And if the United States of America, in certain places, is behind even, not only developing countries, but others, when it comes to infant mortality, shame on us. We can do better, and we will. So thank you.
Thank you, Congressman. Okay, so finally, I'm going to turn to Dr. Diana Bianchi. She is the director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development at the NIH. She also is the head of the Prenatal Genomics and Therapy section of the Medical Genetics branch at the National Human Genome Research Institute. Her research focuses on prenatal genomics with the goal of advancing non-invasive prenatal DNA screening and diagnosis to develop new therapies for genetic disorders that can be administered prenatally. Dr. Bianchi received her medical degree from Stanford University School of Medicine and her postgraduate training in pediatrics, medical genetics, and neonatal perinatal medicine at Boston Children's Hospital and Harvard Medical School. Please, Dr. Bianchi.
Well, good afternoon, everyone. It's such an honor to join my co-speakers who have been just fabulous. And I want to thank the sponsors, the WCPI, Congresswoman, members of Congress, their staff, for allowing me to speak with you today about the maternal mortality crisis in our country. Now, you heard that I direct the National Institute of Child Health and Human Development, but 30% of our portfolio is in reproductive health. So we are the lead funder in maternal health research. You wouldn't know it from our name. And we are absolutely dedicated It's in our strategic plan. It's one of our major focus areas to reduce maternal mortality. But it's a complex problem. It requires a multi-pronged solution. And in 5 to 7 minutes, you can only scratch the surface. So I've decided to focus on 2 areas. You've heard from my co-speakers that more than 80% of maternal deaths are preventable, which means we can do something about this. And it's even higher in American Indian and Alaska Native populations, where 93% of maternal deaths may be preventable. So if I could just have one slide, because I think a picture tells 1,000 words. And I wanted to focus on maternity care deserts, which you've heard about. And this is a picture from HRSA. And I want you to focus on the dark red areas. Those are the areas of maternal care deserts. And that means there's no hospital or birth center offering obstetric care, and there are no obstetric providers. And I actually had asked Dr. Kalins to point out her area, which it's hard for me to do from here. She's got Atlanta in the center, which is a blue area with maternity care, but she's practicing in the red counties that are circling Atlanta. Now, what's in orange? Orange are counties that have low access. They don't have there's no access as in the red counties, but the orange counties have low access to preventive prenatal and postpartum care. That means there's less than 1 hospital or birth center that provides the appropriate care. They're either a low number of providers or a high proportion of women, meaning 10% of more who have no health insurance. So they haven't necessarily gotten the appropriate prenatal care. So this can be either in rural areas, you do see sort of a concentration in the middle of the country, but it can also be in urban areas. And in Washington, D.C., we have some famous deserts that are they're urban maternity care deserts. And the problem is, this is a worsening problem. You heard that hospitals are closing many times without notice. There are a number of providers that are required to provide care around the clock, 24 hours a day, 7 days a week, and it is not cost effective for many hospitals. So what can we do about this? So thanks to Congress, the NIH is performing research to look for solutions. Dr. Kalins mentioned some very achievable solutions. She also mentioned the hemorrhage toolkit, which actually came out of research that was sponsored by NICHD. So we can do research to determine what are the most effective ways to address a problem. And that evidence can then go to the professional societies who make the recommendations in terms of how to treat people, and then Congress can help with providing support to implement those recommendations. So we're very grateful to Congress for providing the funding for the NIH implementing a maternal health and pregnancy outcomes vision for everyone, or the IMPROVE initiative. I left a few folders on the table where the lunches were. We have a 1-pager. We know that people have a short attention span. If you don't get one of the booklets, please take them so I don't have to carry them back, but we will provide the links online for you to print them out. And that is going to give you the highlights of the IMPROVE initiative. Our goal, the IMPROVE initiative is co-led by NICHD, as well as the National Institute of Nursing Research, as well as the Office of Research on Women's Health. And our goals are to reduce preventable causes of maternal deaths and improve the health of women before, during, and after delivery. It includes a special emphasis on disproportionately affected populations, such as racial and ethnic minorities, rural populations, and also people with disabilities. 2 key aspects, so I'm going to focus on 2 aspects in my time, include developing remote technologies to extend access to postpartum care, and the other one will be increasing the workforce to enhance community-based care. And the reason why we're focused on postpartum care is 60% of deaths occur postpartum. It's rather shocking. You'd think that they might be occurring either late in pregnancy or delivery, but it's actually afterwards. So the Improve Initiative is funding the RADx Tech for Maternal Health Challenge, which is like Shark Tank, if you watch that on television. It incentivizes development or adaptation of home-based point-of-care diagnostic devices, wearables, and other remote sensing technologies to improve postpartum health care, particularly in the desert. So while we recognize that the internet may not be available in all counties, most people do have access to a smartphone, and there is cellular service, so we are taking advantage of that. And the technologies target life-threatening issues such as hypertension, postpartum depression, anemia, and hemorrhage. So as an example, one of our 10 finalists is Hemosonics, which has a point-of-care diagnostic device that helps to manage bleeding in critical care settings. And through this challenge, they are adapting it for use in obstetric settings. Another technology was developed by a team at Washington University at St. Louis. They have a remote monitoring system called Maternal Armor, which consists of a wrist sensor and a mobile phone app that healthcare teams can use to remotely monitor any laboring or postpartum patient, particularly those at risk for hemorrhage, because we're focusing on hemorrhage today. If early signs are detected, patients and providers are alerted through their phone app. So we're bringing the technology to the patient. The hope is that these technologies developed through the challenge, through Improve, will help to lead timely interventions and potentially life-saving treatments. The other highlight that I wanted to mention today is the workforce. As you've heard already, there are fewer physicians and nurses who are specializing in obstetrics and gynecology. Those that do are unevenly distributed across the country. This exacerbates the difficulties that many women face in accessing obstetric care. So another part of the Improve Initiative is called Connecting the Community for the Maternal Health Challenge. These are teams that are working to build capacity among community organizations to conduct maternal health research. 3 of the 8 finalist teams are evaluating interventions that include doulas as an extension of maternal care. One team is assessing the impact of postpartum doula care on reducing hypertension and postpartum mood and anxiety disorders among Black, Indigenous, and people of color. They're postpartum. Another is focused on offering culturally congruent doula care. And the third is examining the impact of community-based doula mental health first aid training on mothers' initiation of mental health treatment. Maternal mental health is a primary concern among our community partner organizations. This is across the Improve Initiative. So the Improve program also includes 12 maternal health research centers of excellence across the United States. We wish we could have more. We can't cover the entire country. The awarded projects are addressing not only health conditions that contribute to maternal morbidity and mortality, but also barriers to care, social determinants of health, and discrimination. For example, a project at one center will investigate the effects of housing instability on pregnancy outcomes. Another center aims to reduce substance use related maternal morbidity and mortality by increasing non-stigmatizing patient-centered care. These are big problems for pregnant people. One center is testing a program that incorporates postpartum care coordinators in the community, and another is evaluating a doula-delivered postpartum mental health and cardiovascular intervention. So we're already testing some of the interventions that you recommended. So importantly, the research centers will partner with community collaborators, such as state and local public health agencies, community health centers, and faith-based organizations. We know that one solution doesn't work for everyone. We need to tailor those solutions locally. So we look forward to continuing to work with our partners in all sectors to find solutions to this solvable problem. We all want to reduce maternal mortality. Thank you.
Thank you, Dr. Bianchi, for telling us about all the work that your organization is doing, or probably part of it, because I'm sure that there's so much more that you guys are doing. So really appreciate it. Thank you. Okay, so now it's time for question and answers. So I'd like to open up the floor for questions. Yes, my dear. Right, do we have a microphone? Yeah.
Hello. Hi. Yeah, hello. Sounds like so. Okay. Hi, I'm Alicia. I do health policy for the National Action Network. We specialize specifically in health equity work. And as of recently, I've also been becoming a doula because this work has become a huge passion for me. So I think my question is, I want to go back to the maps, Dr. Bianchi. And thank y'all for being here. This was great. I'm concerned about the locations and where there are maternity care deserts. There's also food deserts, and those are also states that are having more restrictive laws. What are some ways, especially as we're in an election year and we don't know what the outcome is going to be yet, that we can like counteract some of those things to help create better outcomes, considering that the laws are becoming more restricted in some of these places as well?
Are you directing towards one particular person?
It doesn't matter. It doesn't matter.
Yeah, so why don't we, thank you for your question. So who wants to go at it?
Or just maybe just to make the question a little more seamless, what are some of the ways that we can, what are things that need to be implemented, things that we can do to help counteract some of the issues that we see within the maps?
Okay. Maybe we start with Dr. Callens and then Dr. Bianchi, or vice versa?
Sure. So that's a really good question, because it's important for us to think about solving this issue not as just a healthcare problem. And I think a lot of the work maybe previously has been focused on just the healthcare system. But if we do not include our economic development director, our chamber of commerce, our local markets, all of those things are going to help to contribute to that environment that we talked about. And so regardless of what happens politically, we still have work to do. And so we've got to figure out how to connect on those shared values and really start inviting everyone to the table. So when I think about this issue, I don't think, we just need more OBGYNs. No, we need our family medicine physicians. There are a lot of states where they do obstetric fellowships and they practice. I interviewed for a job in Staples, Minnesota. They only had one OBGYN. All the family physicians did C-sections. So how do we expand our policy to address those things? But also, how do we have the time built in to our schedules to administer or prepare a questionnaire and really assess and address the concerns that are going on? And I could not answer your question completely without mentioning the importance of literacy and health literacy. So if we're not investing in our educational system, we're setting everyone up for trouble. Okay. And so it's very important for us to assess where our patients are and how do we propel them forward, but also how do we plant those seeds to make sure that future generations are putting down that foundation that allows them to complete high school and get better jobs and get health insurance and make better decisions and be able to read their medication bottle and know exactly what's going on. And so really, it's a comprehensive effort that is not just a healthcare issue, that's the stimulus. And so we have to think big and broad as we work on addressing those issues. So long answer to your question.
One of the branches in our extramural part of our institute, it looks at family demographics. And so in an indirect way, they are studying the effects of migration of obstetric care across state borders. So we don't have an immediate answer right now, but we recognize that this is an important problem. And this is a bipartisan issue. Nobody wants a mother to die. And that's why reproductive care is really a continuum across the lifespan for a woman, from, what is normal menstrual biology, for example? What are gynecologic conditions that affect menstrual biology? How do you choose to have pregnancies when you want them? And, then how does that translate into later in life, which is menopause? So we're trying to take a lifespan issue, which rolls into the president's executive order on increasing support of women's health research and not narrowing the focus. But we do recognize that, you know, non-medical factors are affecting the workforce. That's probably the best way I can put it. And I believe it's the American College of Obstetrics and Gynecology is tracking what is happening in states that have full access to reproductive care, as well as states that have more restricted access. And there are changes that they're seeing. Fortunately, there is less of an issue in OBGYN than there is in pediatrics right now. Pediatrics, for one reason or another, is not filling their residency programs. But I've been told that that's not as much of an issue in obstetrics and gynecology. People are going into the field, but they are making decisions where to get their training and where to practice. Is that fair to say as a non-obstetrician?
Absolutely. Okay, thank you. Next, yeah, we have a question back there. Back right there.
Thank you. My name is Joy Burkhardt. I'm with the Policy Center for Maternal Mental Health. Thank you for acknowledging the high rates of maternal mortality due to maternal suicide and overdose. I also wanted to acknowledge, when I see the map of maternity care deserts that you shared, what strikes me is that government is focused on roads and infrastructure. We have elementary schools as infrastructure. We have police departments as infrastructure. And when I see those maps, I think, is it not time to think about healthcare infrastructure, starting with maternity care for women in these deserts? Or do we really want to leave it to private firms and not nonprofit, in quote, right? We know those stories around hospital delivery to create, to solve for this. Is it time? Is now not the time to really think boldly about infrastructure, starting with maternity care? Yesterday, HHS released a report from the Federal Maternal Mental Health Task Force, and we addressed the shortage areas, the maternity care shortage areas, also the maternal mental health shortage areas. There's a map that looks just like that one or very similar on the Policy Center for Maternal Mental Health's website on maternal mental health shortage areas. And the concept of a maternity care center, an MCC, is addressed in that paper that calls on this very thing to be considered by Congress. So just would love to get your thoughts. Do you think it's time? Is this bipartisan infrastructure necessary? Or do you think we should continue to kind of try to piece additional solutions together?
Thank you. So who in our panel?
I'll go first. The time is now.
Yeah.
And I loved your reference to infrastructure, because the really nice thing is it's already there. We have health departments, we have fire stations, we have schools, we have the entities where we're intersecting with the community. And so why would we not capitalize on that? But better yet, it's time for us to go to where our patients are. And that's the paradigm shift that really needs to happen. The other point that I will add is, we're in a crisis and we're kind of moving around and we're doing the same thing and it's not working. So we really have to think differently about that. And it's time for us to use that infrastructure a little bit differently. And so I completely agree with you. And I'm hoping that we will stop thinking about it along the political lines, which is hard to do, because people are dying and we can't just stand by and not act. If we see something happening, if we don't say anything and we don't do anything, then we're complicit in that. And so I think the time is now.
I would agree. The time is now. I always say that, we're talking about the future of our country. We're talking about young women who will go on to lead productive lives and, anchor families. And then the children. Obviously, infant mortality is a similar problem with some of the same demographics. I agree about the infrastructure is partially there. There are two things that I think are missing. We need countrywide internet access. Why don't we have that in this day and age? And the second thing, which I have to honestly say, as senator of a rural state, really impressed upon me what a big problem it was, and that was transportation. And you mentioned that too. It's great if we have these remote devices that say this woman is in trouble, but if you cannot get an ambulance to get to her county, it's for naught. So I would add transportation and internet to the wish list.
Thank you. Yes, please, go ahead.
Hi, thank you. I'm a fellow for the Office of Senator John Ossoff, and my thesis is actually on maternal mortality in Georgia for the geospatial social determinants. But I had a very specific question on postpartum hemorrhage. I believe it is 2019 that the JADA system came online, proving to be much more effective than the Bakri balloon. It does not have a generic option, and it is about $1,000 to use each time. But my question is, do you see a way for Congress to be effective in the space to promote education, use, adaptation in the hospital, especially in the rural centers that may not be able to afford that, but may alleviate the funding in the blood loss and transfusions? I would love to see what you see the role of Congress in this space that does not overstep the boundaries for medical professionals. How can we be best positioned to help?
Thank you for the question. So who's going to take that one?
I think you have to.
Okay, I'm going to find a question for Eric.
I'm the line leader. So thank you for your question and greetings from Georgia. So I think that from a federal standpoint, there is a role to play because a lot of the hospitals where they may not have access, there are a lot of rural hospitals where they just really cannot afford to do that. So how do we implement, and I'm just throwing this out there, some kind of cost sharing initiative where we have an opportunity to have that accessibility? And it's important. I love that you mentioned the rural setting because one of my philosophies is that your healthcare should not be determined by your zip code or your geographic location. And so what can we do to make sure that we have one or two in the hospital for say? And the data is helpful. But a lot of the issues that we're having with postpartum hemorrhage can be addressed by anticipation. And so if I have a patient, if I'm in the operating room and I'm doing a C-section and it's her eighth baby, I will have my medicines drawn up and ready to go. Aggressive massage of the uterus and the other procedures that I will not gross you out with. But part of it is really anticipating. And so that training component, it's not going to supersede the access to tools, but we have to be able to anticipate and be able to act quickly to diagnose and intervene. And the cases where we have unfortunate outcomes, in almost all the cases, there's a delay in diagnosis or delay in intervention. And if you don't have a JADA, there's a list of about 10 other things that we can do that we can have access to. And so, you know, how do we make sure that people know what's in their toolbox? And I mean, I trained at Grady Memorial in Atlanta. Sometimes you don't have everything you need, but you have to figure it out because you got a life on the line and that mom needs to go home with her baby. And so, yes, we do need access to some tools that could be helpful, but the anticipation, the diagnosis and the intervention, that paradigm is how we can get ahead of things.
Great. Thank you, Dr. Kellens. So I'm going to actually build on that a little bit. And you talked about interventions that they should know. So I'm going to ask a direct question, and this is actually maybe starting with you, Erica Lynn. What interventions have been shown to be effective in reducing maternal mortality? And what are some best practices for ensuring that women receive appropriate care before, during, and after pregnancy?
So one of the biggest interventions, as Dr. Callan said, was anticipation, right? So if you look at the medical history of a patient, you can anticipate that based on this medical history, they may be at a higher risk for developing X, Y, and Z, or family history. They may be at risk for developing some sort of preventable occurrence from happening. So just taking a look at the medical history and anticipating what things you may need. Also to the point that she said, looking at all the things that are in your toolbox. Maybe there are some, because you have to think about it. People have been delivering babies for so long, right? So all of these fancy devices and things like that were not always in existence. There were things that were used beforehand that still may be available. So some rural areas may not have the best technology, or they may not have the best resources, but they may have something that's potentially comparable, which then really makes the healthcare provider rely on like the information that they have. I think a lot of times just with the development and advancement of technology and things like that, we get so used to using the easy thing, right? So I'll use it, basic blood pressure, right? We use these things called Dynamaps, and you put it around the patient's arm and the number pops up. Well, sometimes that could be wrong. Do you know how to use a stethoscope? Do you know how to use a manual blood pressure cuff? So I think a lot of times we rely on these things in medicine and I love the way that things have advanced. I love the way that we have new things in our toolbox that are, better used, and they work a lot better. But sometimes we may have to go back to basics because maybe we're in a place where the budget is not as big. So they can't afford to have the things that larger hospitals have. And so knowing how to intervene and use your brain to say, okay, I have this patient, this is what's going on. These are the things that I have available to help in this immediate moment. So getting back to using your brain and your resources to treat the problem at hand versus relying heavily on technology and the fancier quote unquote things that are available.
Could I
Thank
just
you very much.
amplify something that Erica Lynn said? And that's at the very beginning, you said you need to listen to the patient, you need to take the family history, the prior medical history. And the CDC has a wonderful campaign called Hear Her, again, Georgia reference, Hear Her. And it's really shocking when you become aware of all these stories where the person herself is aware that something is wrong or the care provider is not paying attention to something. I mean, the classic example is Serena Williams, who'd previously had blood clots. And then she develops a pulmonary embolus postpartum. And she told her care providers that she was at risk for blood clotting, and they didn't listen to her. So it's, if Serena Williams is not being listened to, what's going to happen to the average person? So we really need to listen. And I think that basic marketing campaign of the CDC was brilliant, to listen to our patients.
Very important message. Thank you, Dr. Bianchi. Okay, coming back to yes, so lady in the back.
Thank you so much. My name is Shabani, and I'm an intern in the Democratic Caucus, but I'm also a PhD student in epidemiology at Ohio State University. Ohio also has awful infant mortality rates and maternal mortality rates. And I know, Erica Lynn, you talked a little bit about doula care during your pregnancy. And then I know, Dr. Bianchi, you talked about multiple interventions and programs that are exploring the use of doulas. What is it about doulas specifically that seem to attenuate the adverse birth outcomes? Is it like the fact that they advocate for their patients? Is it the fact that, I'm just curious about what you guys think about that.
So in my experience, it's more about the advocacy, right? So you can't ask a question that you don't know to ask. So doulas are not trained medical professionals, but they do get trained on pregnancy, postpartum, all of those types of things. So they have a little bit more knowledge of what the mother may experience during pregnancy. So the doula typically is able to ask questions and advocate in a way that the patient may not be able to, because the amount of information that the patient knows may be limited. And so they're able to advocate and step in ways that maybe also some hospitals, I know I live in Philadelphia, some hospitals are starting to adapt more to a doula policy. So it's a little bit of camaraderie that happens with the doulas and the medical professionals. So if I'm a patient and my doctor doesn't really have a you know, they don't know me, I'm meeting them for the first time. Maybe they do know Alexia, who's my doula, who does so many deliveries there. So they may be more likely to listen to Alexia versus listening to me because I'm a patient that they are just meeting. And so the advocacy is really where doulas, I believe they are really, really helpful. Because the patient feels more comfortable talking to the doula because the patient knows the doula. I know a lot of times if a doctor comes in and asks a patient, do you have any more questions? The patient's like, no. And then I come in as the nurse and they have a whole list of questions, like the doctor was just there. And so I think a doula creates a great middle ground of the patient is comfortable with the doula. So she talks to the doula about the concern, and then the doula is able to advocate to the healthcare provider.
Excellent. Anyone else want to add? Do you want to add? Please go ahead.
So I want to highlight something very important, and I'm going to use another quote. I'm sorry. So there's a quote that I love that says, "Change happens at the speed of trust." But I've adapted that now to transformation happens at the speed of trust. And what I keep hearing as a running theme is the connection between the patient and their healthcare provider. And we have an issue there. And it is our responsibility as healthcare professionals to establish that trust, whether or not it was with the doula, the nurse, the doctor, the family medicine physician, the midwife. And so we have to learn to connect with people, not just their problem. We talked about that earlier. And so I really want to highlight the importance of how we improve the provider-patient relationship. And when that is there, it becomes a bridge that really helps things to happen. And keep in mind, sometimes when patients come in, you have to build new bridges or you have to repair bridges, and you have to know which one you're working with, and you cannot do that in 5 minutes. So that means we have to create some space. If you sit on the side of the bed and just say, you know what, tell me what's really going on, you're probably going to get that feedback. And so I really just want to highlight the importance, I'm not sure what that is, of, okay, the importance of that trusted relationship. And that's what's being attacked a lot. And if we don't have the time to do that, it adversely impacts the patient and their outcomes.
And I'd just like
Yeah,
to
please
add
go
that doulas and midwives often are able to visit the patient a few days postpartum in their own home, which is an enormous advantage. I think it's very difficult to ask new families to wait 6 weeks until you go back to your primary obstetric provider. One of the things that we are looking at is how does that postpartum visit play a role in improving health outcomes and seeing the person in their own environment. Maybe they're not feeling well enough to actually get on a bus and go to a clinic. It's really an enormous opportunity for both education and prevention.
Excellent point. Thank you. Okay, we have another question in the room. There's the mic.
Hi, thank you so much to the speakers and the organizers. I'm Lisa Noguchi. I'm Director for Maternal and Newborn Health at JPIGO, which is the global health implementation arm of Johns Hopkins University. My background is I'm a nurse midwife and an epidemiologist. And when I'm not working on global health and maternal mortality outside the US, I'm a fellow labor and delivery nurse at WellSpan Health System in a rural county in Pennsylvania, Adams County, level 1 community hospital. It is a hard time to be a nurse right now in the world, in the US and in the world in general, huge nursing shortages. So I would love to hear, what are your thoughts on addressing the global, but especially the US shortage of nurses? And Erica Lynn, what is your advice to labor and delivery nurses right now?
Excellent question. Okay.
It is indeed a very difficult time to be a nurse. I think that the hospital structure itself plays a huge role in why nurses have decided to do so many other things. I think COVID showed us how needed we are, but also how unfortunately abused we are as well, right? And so in these healthcare systems, you just sometimes aren't treated the best. And so if it's not something that you're passionate about, you're going to go wherever pays the money. That's why we have so many desert routes, right? Because not only for nursing, but all healthcare providers, you're going to go to whoever pays you the most and who's going to treat you the best. And unfortunately, there's a shortage in how well you're being treated in these areas. And so I would really say my encouraging word is, especially for maternal health, is that we all know a woman, right? We have mothers, we have aunts, we have cousins, we have best friends, we have neighbors. If you think about each patient as a human, as someone who's someone's aunt, someone's cousin, you can bring the heart back to what you do, because most nurses became nurses because they wanted to help. So really getting back to the basis of, why did I become a nurse and what change do I want to make? I think that's the best way to encourage people who are in nursing and in healthcare in general. And to everyone's point, just kind of getting back to that human interaction of, hey, how was your day? How are you feeling? Instead of, oh my goodness, I have all these other things going on. Let me just run in room 5 real quick. And so my encouragement would be to get back to the basis as to why you decided to go into healthcare in general, and what change you want to make in that atmosphere.
Well said. Thank you. Okay, so now, since we're coming close to the end of the time, I have to put in my mandatory questions. This is for all the speakers. So in 1 minute or less, what are 1 or 2 primary takeaways you hope that the policymakers attending or listening on will consider in their work? Maybe I'll start with Dr. Bianchi.
Yeah, so I thought about this and I want to keep it simple, but remember that over 80% of these deaths are preventable. We're not talking about, putting someone on the moon, which of course we could do, but this is a solvable problem. So that's point number 1. The second thing is to not ignore the year after delivery, because that's where the majority of deaths are occurring. So it's one thing to think about pregnancy as, a discrete 9 months, the baby is delivered, the baby's handed over to the pediatrician, and essentially the obstetrician's work is done. It's not like that. And there's a gap between the handover from the obstetrician to the internist. And that's an area I think that needs more work to be able to identify who is at risk for these postpartum complications of death. So those are my 2 points.
Great, thank you very much. Dr. Killens?
Sure. So my 2 points are how we empower our caregivers. And we talk about a lot of the deaths happening, 42 days to 365. They're not in the doctor's office. They're in the grocery store, they're at school, they're sitting at the hair salon. So how do we use the Hear Her campaign and educate everyone? We have someone in the audience, I won't look at her right now, that's pregnant. And so the first thing I did, I looked at her ankles to make sure she wasn't had any edema. But how do we develop that same kind of assessment that we're doing? We talk about hair color, clothing, all that good stuff, but we really need a community culture of care. And I think we can work on that. The other thing I'd like to really make a shout out for is, and there's someone in the audience who's wearing a beautiful pink suit. Barbie got it right. Preconception care, everyone needs access to a gynecologist, okay? What happens before pregnancy is huge. There are a lot of women that do not have regular access to care. They do not have the advantage of preconception care. Let me optimize your weight. Let me optimize your blood sugar. Let me optimize your hypertension disorder. Let me make sure you're on the right medicine so that when you do get pregnant, you're not discontinuing your medicine prematurely, putting yourself at risk because you're worried about harming your baby. There are medicines that we can use. So that preconception care point is not something that women have regular access to, nor are they utilizing it the way that we would like them to, so that they go in with that advantage. And it brings me so much joy when I get a chance to talk to someone about planning their pregnancy, because I get a chance to say, let's do this better. Can I have 6 months to, get things right? But everyone deserves access to preconception care to help them in that respect.
Excellent, thank you very much. Erica?
Yeah.
Lynn?
And I just have one thing. So for policymakers, I think we've heard the information, we know the statistics. We keep having these briefings and the information is out there. I think a lot of times the policymakers, they hear it is in one ear and out the other because they're so far disconnected. But to my point earlier, every policymaker, whether you're a man or a woman, you know a woman, right? So you may have a daughter, you may have a sister, you may have a mother, you have a woman who is impacted by the numbers, by the statistics, by the deserts. If you look at all of the information that we talked about here, even the other information that's available, if policymakers attaches a face and a human body to what we're talking about, they may feel more passionate about not, this is just another page on my desk for something I need to get done today, but no, this is actually an area and it's something that needs to be handled. I think it's important for policymakers to understand that this is a major issue, not only a fictitious thing that we're talking about or words on a page, but there are human beings attached to the things that are happening.
Awesome. Thank you very much. And I turn it back to Cindy.
Well, thank you so much to our speakers for your inspiring presentations. I thought the last comments that each of you made really tied this together beautifully. We have our call to action. Thanks also to Shefali for such a great job of moderating the panel. Clearly, there's significant interest in this topic. We're so lucky to have so many advocates, both on this panel and out in the audience. Thank you to all of you, and also to those on the live stream. There are a number of really exciting people on this live stream, so we're expecting a lot from you too. We hope our speakers' insights and personal experiences will contribute to successful bipartisan solutions. This conversation obviously was recorded. We hope it will be available for viewing this week, certainly by Monday. I looked out at the staff before. We'll do our best. A short survey about today's discussion can be accessed through the QR code, which is taped all over or on chairs. We hope that each of you will take a few minutes to respond. We also encourage anyone attending remotely to take the time to fill out the short online survey that will immediately appear on your browser at the end of the briefing. Our thanks again to the Bipartisan Women's Caucus leadership, both members and staff, and to Organon for your support. And finally, my thanks to the amazing WCPI team, Alyssa Innes, Efnan Adam, Annabelle Green, and Tharunika Govindasamy. Thank you for your work to make this briefing possible. And thank you all for joining us.